Hi guys, it's Dr. Jackman today, and I am going to continue my process on egg freezing. Now, I know that it's been a while, and I apologize. I just got caught up in a lot of things, but we're back on track, okay? So far we discussed how to choose a clinic and a physician, how to decide whether or not you want to do egg freezing, some of the reasons why you may choose to, and my personal reasons why I chose to do it, why I chose to consider it. And now we're going to talk about the actual process. So the process of egg freezing, you first have to stimulate the ovaries to produce as many eggs as possible. So I don't know if you watched my video on menstrual cycle where we kind of discussed this, but I'm going to go and do a brief overview, and then I'll speak a little bit more of the medications. So today here I have a handy dandy uterus, and this uterus has a lot of pathology, so don't focus on it, but it's just to give you the actual uterus. Okay, so this is the vagina, this is the cervix, which is the mouth of the uterus, and this is the uterine cavity. In this uterus example, there's a lot of things in it. Most people wouldn't have all these polyps or fibroids or endometriosis, so bear in mind of that. These are your tubes, once again, and these are your ovaries. Okay, so this is the general thing. Now every month your brain produces a hormone called FSH, follicular stimulating hormone, to stimulate one follicle in the ovary. Now actually your ovary is going to wake up several follicles every month. Now if you see on this one, this is like a display of the different follicles, even though technically it's a corpus luteum. Anyway, let's not get technical. So the ovary has several follicles being woken up every month, and your brain produces FSH to stimulate the ovary to grow those follicles. Now the amount of FSH your brain produces naturally will eventually just naturally select one of the follicles to get really big, and that will be your follicle that will eventually ovulate and release the egg that could potentially help you get pregnant. Now if your body wakes up hundreds, thousands, 20, 30, how many of the follicles your body wakes up, your brain doesn't stimulate all these follicles to grow into getting mature, and hence you won't release all these eggs. You literally just release like one egg every month, so you lose the rest of the follicles essentially. So when you're doing IVF and egg freezing, we're talking about egg freezing. So when you're doing egg freezing, what we do is give you medication to stimulate all the follicles your brain would grow to grow. So if your body woke up 20, 30, 40 follicles, we try to get at least 75% of them to grow and get big and get dominant. So the medications we use help us grow the follicles. Now what grow the follicles? Remember I said it earlier, the follicular stimulating hormone, FSH, produced by the brain. So that's the same mechanism we use to grow the follicles, and the follicles contain eggs. And that's the same mechanism we use when we're doing fertility. So I have a couple medications here with me. I don't have the major one, which is an injectable, but I'll still tell you about it, okay? So one medication, and this is literally the medication I was prescribed, just making sure I have no personal information. So one of the medication is letrozole, and letrozole is basically a medication called an aromatase inhibitor. So when your follicles start to produce, when your follicles start to get stimulated by the FSH, they all begin to grow and they produce estrogen as an end result. Now to get to estrogen, a lot of like substrates and products is produced along the way, and then like the final step before estrogen is that you have something called an aromatase. It's an enzyme, and that helps to convert the substrate into estrogen. Now this special drug, letrozole, this drug blocks that enzyme from working, so essentially you don't have the estrogen being produced. Now how does this help you grow follicles? Well, the brain uses that estrogen that your body is producing as a way to feed back on itself to know if it should continue to give you more FSH to stimulate follicles or not. So if the brain realizes that there are follicles because you're producing estrogen, the brain gets a sense after a while. Initially it causes you to produce more FSH, but after a while it tells the brain, okay, you can stop, I have follicles. Okay, so the estrogen is a sensor for the brain to know what to do with respect to your follicles. Now if you block with letrozole, the brain from producing, I mean, if you block with letrozole the estrogen production, even though your follicles are growing, the brain can't really sense it that well because you don't have as much estrogen being produced. So this tells the brain, oh, no estrogen means no, she doesn't have any follicles. Let me give her more follicular stimulating hormones. So the brain generates more FSH. And we're still blocking it. So you keep generating more FSH. So this medication we don't typically use that long because estrogen production is one way that we monitor your how good you're doing in your stimulation when you're doing egg freezing. So we use it for a few days, not that long, because we really eventually would need to monitor the estrogen. So that was one medication I was prescribed personally for my egg freezing journey. The second medication I was prescribed is a drug that many people, if you have fertility, if you're going on a fertility journey, you may know this medication. This is called clomiphene citrate. I don't know if you could see it. It's clomiphene. So clomiphene is called a selective estrogen receptor modulator, and this is just a fancy way of saying that it sits on the receptor that estrogen normally sits on, and it blocks the receptor. So it doesn't do anything to the receptor. Some things sit on the receptor and activates it. This sits on it and just blocks it. So once again, your brain doesn't sense that you have produced estrogen, even though you are producing estrogen. The brain doesn't sense it because this medication is blocking the estrogen from being sensed. So once again, the brain produces more FSH. Now, even with all these two medications, the brain could only produce on its own so much FSH, follicular stimulating hormones, to grow the follicles. Realistically, in young patients with PCOS, or anyone who's going to have like a large amount of follicle production, your brain would not be able to produce enough FSH even with all these extra stimulation. And that's why in most IVF centers, you get an injectable FSH. This way, we don't even have to rely on the brain. We just give you the amount of follicular stimulating hormone that you need. So you're getting it externally. You're injecting yourself with it. And I'm showing my hand, usually injected in your abdomen. So you're injecting yourself with the follicular stimulating hormone. And hence, this hormone will stimulate the ovaries, in a diagram, stimulate the ovaries to produce lots and lots and lots of follicles. As I said, how many ever you woke up, we're going to try to stimulate to get as many follicles as possible. So that was my treatment regimen. I was going to take letrozole, I was going to take clomiphene citrate, and I was still going to supplement with follicular stimulating hormones because, as I mentioned in a previous video, I do have polycystic ovarian syndrome, and being on a relatively younger side of things, that I was expected to get many follicles, many eggs, so hence I was going to be on some injections. Now, the clinic I worked for previously, the fertility clinic, they had many different protocols, which was really cool because we could tailor your stimulation based on your particular need. So for patients who had something called like diminished ovarian reserve, meaning that you had less follicles and you weren't anticipating to get many follicles, then using FSH was a bit probably too strong, and we could have probably just stimulated you just on the oral tablet medication. And then if you had a lot of follicles predicted to have like a lot of eggs, then we could have gone more on the injectable sides. Most clinics, though, I would say, stick to conventional IVF, and that will be more or less using the injectables, not even necessarily using any oral medication, so no tablets necessarily, just basically giving you the injection for follicular stimulating hormone. I should be pointing to my stomach for the injection for follicular stimulating hormone. So the process, number one, is to stimulate the ovaries to produce the follicles. The follicles, most will contain eggs. So that's the first step of the process. We're going to produce the eggs. And as I said, producing the eggs, there are many different stimulation protocols that you can do to produce the eggs, but the more popular one is conventional IVF, where you're going to take injectable hormones. So example of these injectable follicular stimulating hormones are like gonal F and Follistim. If you ever did any IVF or egg freezing cycle, you'll be familiar with this name. There was also one called Menopur, because this one had FSH and LH. That's another hormone produced by the brain. It was a combination injection. So these were the three more common injection medications that people use, and this had FSH in it, so we weren't relying on your brain. We were just we're just giving it to you. We're just giving it to you. It's like, I need to build a house, I can give you stimulation to make you build a house, or I can just give you a new house. So FSH is just like, I'm just giving you a wet ready-made house already. And letrozole and clomiphene was more like, I'm giving you the motivation to get your bricks and your cement to build that house. So that's more or less, we have to stimulate you first, and once stimulated, we have to monitor you. So when you're on any fertility medication, even clomiphene, which a lot of GYNs use, you have to be monitored. You should never take these medications and not be monitored, because these medications are going to make you produce more follicles, which will have more eggs, and your risk of having multiples is higher, even if you're doing something like timed intercourse or an artificial insemination, intrauterine insemination. So we should be monitoring you, and part of the process of my egg freezing journey was being monitored. So you get monitored with blood work. As I mentioned before, we do check your estrogen to see how your response is, because estrogen is a product of the follicles. And then we also check your follicular stimulating hormone level, your luteinizing hormone level, and your progesterone level. Those are like some basic labs that we do to check you every couple of days, every week. So it just depends. It differs from person to person. So you also get monitored using an ultrasound. So the ultrasound would be able to watch the ovaries and see how the follicles are getting bigger. So if the follicles are being stimulated and they're actually responding to the stimulation, then they should be growing bigger and bigger every day. 1 to 2 millimeters every day is typically the rate of growth that we average. So first you get stimulated, and then you're being monitored throughout the process. And this is the first step in actually doing an egg freezing cycle. After your consultation and you've agreed and you know what you're going to do, these are the first steps. Now, what I described more or less sort of focus more on conventional IVF, and then a slight twist to the conventional IVF using like a less injection protocol. However, there's also natural IVF, which is just that you allow your body to produce the one follicle that it was going to produce anyway, and then we just retrieve that in an egg retrieving process. So we stimulate you typically, and you usually use these medications for around 8 to 12 days, because that's naturally how long typically most people would be in the growing phase of the follicle. This will change if your cycle is a bit longer or shorter. It will reflect that, but on average I would say 8 to 12 days of stimulating medication. You'll be monitored during that time while you're being stimulated. And then when your follicles are big, and big is 18 millimeters to 22 millimeters, they're just about ready to be mature. So a lot of time your body senses the level of estrogen and it will want to trigger. You may have heard of something called a trigger medication, and this medication is basically to help you ovulate. So when you take this medication, and your body naturally does this with a hormone called LH, luteinizing hormone. So when you take this medication, it tells all the follicles, the eggs in the follicles, it says, okay, mature. Why do we need mature eggs? Because these are the eggs that are going to be able to fertilize. So before maturation, your egg is stuck in a process called meiosis 1, and I will not go into the details because I know I don't want to get down into it, be too complex. But the trigger medication helps the egg to become to finish complete meiosis 1 and to go into meiosis 2, and this is like a part of egg cell division. So only M2, or eggs that are in meiosis 2, can be fertilized, and that's why we need that trigger medication. We do not want the follicles to actually ovulate, not for when we're doing egg freezing, because then we're going to lose all of them to the body if they actually ovulate and open up. So we're giving you the trigger medication, and we're giving you at a certain time so that within 36 hours we do the egg retrieval process. So I stimulated you, or we got stimulated with hormone medication. We monitored with blood work and ultrasound every few days, and now we have large follicles that are ready to ovulate. But instead of letting the body do it on its own by the body releasing the LH, we want to take control. Your IVF doctor is going to take control and give you a trigger medication. Trigger medication typically comes in two forms. It can be medication called Lupron, and this medication tells your brain to release the luteinizing hormone, the LH, that it naturally produced. But we do it with Lupron so we can time, so we know 36 hours we come and retrieve those eggs. Or we can do it with a medication called Ovidrel. Ovidrel is actually beta HCG, which you may know is your pregnancy hormone, and this hormone shares the same receptor on the ovary as your LH, so it actually triggers the ovary to ovulate, to have the ovulation process the same way LH would, because they share that receptor and they activate the receptor together. They're usually not present at the same time. Obviously, if you're pregnant, the beta HCG will come after you ovulated. But I guess someone realized that we can use this medication and it triggers the receptor the same way, even before ovulation, and it triggers it to ovulate. So it was pretty cool discovery. So those are the two medications that could be used, and generally there are slightly different reasons that may make you choose one or the other. For example, if a patient has like a lot of follicles and you think that she may be at risk of ovarian hyperstimulation syndrome, you may opt to use or you should use Lupron, because it lasts for a shorter space of time, whereas Ovidrel lasts for a very long time and can really aggravate ovarian hyperstimulation syndrome. I will get to what that means at a little later on the video. So you take the medication, so it's either going to be Lupron to release your brain's own LH, or Ovidrel, which is going to act like as LH, but it's a beta HCG that's going to sit on the receptor and activate it the same way. And all those follicles that have eggs in it, that are beyond a certain threshold, the eggs are going to mature, complete meiosis 1, go into meiosis 2, and then get stuck at a particular stage. And the last step will be to actually ovulate, which would be to the cells around the egg expand, the egg is now floating in the fluid. The last step will be for the follicle to rupture and the egg to be released. We don't want that step to happen, which is why we time 36 hours. 36 hours for most patients is like a nice time where we can get the egg maturation process without getting the follicular rupture. We want those follicles to remain intact, because that's how we get it. We get it by bringing you in around 36 hours, doing a transvaginal ultrasound, so the ultrasound that goes through the vagina, and I will demonstrate with my model uterus. So we put the ultrasound, pretend my pen is the ultrasound, we put the ultrasound could go up to here, which is the cervix, so it stays in the vagina, and then we're able to watch the ovary with the ultrasound, and my fingers, yeah, and then we guide a needle through the ultrasound machine into the follicle, and when that needle reaches into the follicle, we suction all the fluid, and guess what's in that fluid? Our mature egg. So then we would draw the needle, and we can put that needle into all the follicles we see and get all the eggs. And once we're finished with this side, we would draw a needle, and now we aim to this ovary, and then we get our needle in, and I wish I had a needle, and we suction all the eggs, and all that fluid that we get from each follicle, we're able to suction the eggs. And then an embryologist goes through all that fluid, see how many eggs, how many are mature. There's a way the embryologist under a microscope could tell for egg maturation, and then we have your eggs. So that's perfect. We have the eggs. Now what? So once the embryologist looks at the eggs, the embryologist makes sure that the eggs, for all intents and purposes, generally look good. There's no real way to tell the quality, but some eggs we can tell off the bat are not good. It may be it's not good, it's called degenerated, but but most of the eggs, if they're good and mature, the embryologist also checks for maturity, and there's a way to do that by checking something called a polar buddy. And then once we have mature eggs, we freeze it. Now, freezing is not like sticking the eggs into a freezer like what you have with your fridge. That will damage the eggs, because liquid in the cells, the cell cytoplasm, which is the liquid in the cell, will expand. Remember, all liquids expand on freezing, and that will damage the cell membrane. And basically, that's what we used to do long, like in the back in days, that's what used to happen. And when you thaw those eggs, a lot of those eggs would have been lost because of that expansion. So now when we freeze eggs, we do something called vitrification using liquid nitrogen, and it's a rapid flash freezing, which means that that expansion really doesn't happen because you freeze it so quickly, and you actually use a liquid medium to swap the cytoplasm. So that vitrification, flash freezing, freezes the egg as is. It's almost like if it's a crystal glass ball. So the egg freezes as it is instantaneously, and it preserves its shape, its membranes, everything is intact as it's supposed to be. So now when vitrified eggs are thawed, which is the reverse process of freezing it, guess what? We get back at least 95% of them, way more than we used to get back with, slow freezing. So vitrification has really revolutionized and changed IVF a lot for patients, because this is how we froze our eggs. So I actually do have a video of like my initial processes before I stopped. And my next video that I will make pretty soon, trust me, it won't take 2 to 3 weeks, I will discuss my individual journey. You'll see the video. I'll discuss my individual journey a little more detail and why I actually never froze my eggs. I know, so disappointing. So if you have any questions, I know this was a little heavier video, with a lot more detail and a lot more explanations, so you may have questions, but if you do, feel free to message me directly under the video or in my inbox, and I'll happily answer it. I do like to explain a little bit how things work, and I hope I simplified it enough. If not, I can always make a new video just explaining a little more detail, whatever part of the video was more confusing. But for recap, the process of egg freezing is you're going to take medications that will stimulate your ovaries to produce a lot of follicles, to produce a lot of follicles that your body already started to wake up. Once the follicles, you're going to be monitored with ultrasound and blood work to track your process and your progress, and to know if we should alter medications one way by increasing it or lowering it down. Once the follicles are big and we think they're ready to be retrieved, we give you a special injection that will begin the ovulation process. This is called a trigger shot, and this begins the ovulation process. And the important aspect of this is that we want your egg to mature, but not we don't want the follicle to actually rupture. Then we bring you in 36 hours after, typically, to do the egg retrieval process, which is a transvaginal ultrasound most of the times with a needle attached, for us to withdraw all the fluid from the eggs, from the follicles, and the fluid will contain the eggs. Then you have an embryologist, a specialized person who's going to look at this fluid under a microscope and look at if you have eggs and if they're mature. And finally, we're going to do vitrification, which is the egg freezing process. So this is, the process in a nutshell. If you have any questions, please feel free to message, and I will explain it way better than I have if it was confusing. I hope it wasn't, though. And then my next video is going to be on my literal journey. I actually did video my first ultrasound, filmed all the paperwork, the first ultrasound, my blood work, taking some of the medication, and I didn't really reach too far in my journey. I may have to do it again at some other time, and then after this I will in detail explain why I couldn't do egg freezing, what hindered my journey, and lastly I will do a video explaining what to expect after egg freezing. How could you use your eggs after you froze it, and then some of the symptoms that you can experience on the day. So I know this is a lengthier video, I know this is a more in-depth video. Give me feedback if you have any questions. I will see you soon, and it will be soon. I wouldn't be missing in action for so long again. Have a good day. Bye bye.